give a demonstration of palpation of the hand and wrist. One thing that tends to be helpful is if you are systematic about your palpation. One thing that I find very helpful is it's very hard to say, oh, that's the capitate, or that's the scaphoid, or that's the hamate. I know I'm in the ballpark, right, because I was lined up correctly, but it's always helpful to have a starting point that you know that you can find. So for example, when I'm trying to palpate any of the distal row of carpals, I generally find those carpals by palpating the metacarpals. And I know that at the base of my first metacarpal is going to be the trapezium. At the base of my second metacarpal is going to be my trapezoid. At the base of my third metacarpal is going to be my capitate. At the base of the fourth metacarpal is going to be my hamate. At the base of the fifth will also be my hamate. You can tell you're on a base because the base is a little bit flared, so it's going to feel like a bump. So if you run your finger down the shaft, you'll definitely feel a bump as you're approaching the base. Okay, same thing is true as you go down all these metacarpals. Now remember that the mnemonic for learning the carpal bones from the proximal layer, moving from lateral to medial, you have the mnemonic is generally some, lovers, try, positions that they can't handle. So some, scaphoid, lovers, lunate, triquetrum, and on the volar side of triquetrum is pisiform positions. That is trapezium at the base of the first. That they is the base of the second metacarpal is trapezoid. Can't is capitate at the base of the third. Handle is the hamate at the base of the fourth and fifth metacarpals. All right, so right now what my goal is going to be to find that distal row of carpals. So the way that I do that in a most predictable way is I'm going to palpate the length of that first metacarpal. And generally speaking, the more relaxed your patient is, the less tension there is on the soft tissues, so it will be easier to feel. So what I would suggest is palpating along the dorsal aspect of the digits, because remember that along the dorsum you don't have big fat tendons. The tendons are more flat, so easier to feel. So if I palpate down the dorsal shaft of the first, I'll definitely reach a point where I can feel a bump. All right, and that bump, if you run your finger proximal to the bump, so the bump is running this way, and if I palpate along this, I'm going to feel a divot. Right, so basically when you're trying to feel a joint line, palpate perpendicular to the joint line. You want to cross the river, so to speak, as opposed to going up and downstream, because if you'll feel the bump more as a divot if you go crossing it. So that's the bump. So I know that this is the base of the first metacarpal, and I know the bone just proximal to that divot is going to be my trapezium. Okay, so I know that I'm on trapezium if I've crossed over the base of that first metacarpal. In the same way, I can find the trapezoid. I palpate down the length of that second, and I might need to move the wrist a little bit. I know that I can get my carpals to become more prominent dorsally if I have the patient flex their wrist a bit. So for the purpose of this demonstration, I'm going to have the hand in this position. Normally, I'd probably palpate it in this position, but I'm going to have it like this just for sake of visualization. So I'm going to palpate down the first metacarpal. I'll feel the bump at the base of the first metacarpal. Now just proximal to that, I really don't feel much because there's some space as I push down in trying to feel that trapezoid. So I'm going to flex the wrist, right? And I'll feel the trapezoid come right up into my finger. If I'm not sure if I'm on the trapezoid, go back to the base and feel for the divot in between. And put the wrist back in neutral, the trapezoid goes away, flex the wrist, the trapezoid comes back into my finger, okay? Do the same exact pattern with the base of the third. So find the base of the third metacarpal. Okay, I think I'm on the base, but I'm not 100% sure because there's some nice robust tendons there. So I'm gonna flex the wrist so that the capitate comes into my palpating finger. So now I can feel the capitate because I've crossed over the joint space because that divot. So now I know I'm on the capitate. Here's the base, here's the divot, here's the capitate. Same thing with the fourth. Palpate down the length of the fourth, get to the bump, which is the base. I think I feel a really good divot there now, but just to prove a point, I'm going to flex the patient's wrist, and I'll feel that divot even more as it opens up when we flex the wrist. And now over here is hemate. Here's the divot, the joint space, and here's the base of the fourth. I do the same thing. Here's the base of the fifth. There's the bump. Palpate for the divot just proximal to the bump. I can have the patient flex their wrist and maybe even deviate a little bit, and that hamate comes right up into my finger. Okay, so that's the distal row. You can palpate the proximal row as well, and one of the bones that I would encourage you to be most precise at palpating is the scaphoid bone. The scaphoid bone being the most in the proximal layer and is the most lateral bone in the proximal, sorry, not layer, but row. All right, the scaphoid has limited blood supply, and so therefore, if traumatized, if potentially fractured, has a fairly high incidence of non-union. So it's very important to be able to determine whether a patient needs a radiograph or not. So generally speaking, if you see a patient with trauma, with a fouche, fall on an outstretched hand, and you suspect there is tenderness within this on the scaphoid, that's an indication to immobilize that patient and send them for a radiograph. Remember that radiographs may not show a fracture initially, might have to wait a few weeks to see healing of that. So the scaphoid is really important to be able to palpate. So the best way to kind of get in the ballpark for scaphoid is to have the patient show your snuff box. So extend that thumb. Might not be obvious in everybody, but if you come to the anterior part of the wrist, I can feel that. You can kind of see it if I spread the skin a little bit. That's the anterior part of the snuff box, the anterior border. The posterior part of the snuff box, remember, is that extensor pollicis longus tendon. If you palpate just kind of broadly across the dorsum of the wrist, you'll feel the dorsal tubercle. And on the medial side of the dorsal tubercle is going to be your extensor pollicis longus. So go from dorsal tubercle over to the thumb. Go ahead and resist again. And there, right there, between the dorsal tubercle and the thumb, there's my extensor pollicis longus. So here's the anterior part of my anterior border of my snuff box, or not mine, but Trenton's snuff box. So if I go right in that snuff box, then I know that I'm right in there in the scaphoid, but it's pretty squishy. I'm not very confident that I'm right on the scaphoid. So again, what am I going to do? I'm going to move the wrist so that the carpal bone slides into my palpating fingers. So that means I'm going to ulnarly deviate the wrist. And when I do that, the scaphoid slides right into my palpating finger, slides laterally whenever I ulnarly deviate. So now that I'm very confident that I'm on the scaphoid, and I can even be confident, here's scaphoid. If I come down to the base of the first, I feel my divot at the base of the first, and I can find trapezium. And if I flex the thumb, right, I know that the metacarpal base slides in the same direction as flexion and extension. So if I flex the thumb, I will be able to feel that joint space at the base, and may even feel that joint space between my scaphoid and trapezium even better. Right? But generally, how do you find the scaphoid? Go to the snuff box, ulnarly deviate the patient, and that scaphoid will pop right into your finger. Move a little more distally or higher up, if you will, in the snuff box. Find the base of the first, and then you know you're on the trapezium distal to the scaphoid. Okay? From the scaphoid, we know that we have the lunate, some lovers. So the lunate is just medial to the scaphoid. So if we find the distal part of the radius right there, and to find the distal part of the radius, we kind of push up into the end of it. And what would be the better position to try and palpate that? Would we want the wrist in flexion, or we want the wrist in extension? In flexion, the tissues are going to be more taut, but the carpal is more obvious. But now we want the distal end of the radius more exposed. So I'm going to put those tissues on slack, and now I can very clearly bump up into that most distal aspect of the radius. All right, so if I find my scaphoid bone, go ahead and relax your hand here. All right, I know just medial to my scaphoid is going to be my lunate. Again, how do I get my lunate to pop up into my thumb? Flex the wrist, and it very prominent pops up in. And you can, if you go back to the base of the third, you can find the capitate and differentiate that from. You can differentiate the capitate from the lunate. Okay. All right. So to find the hamate, find the head of the ulna, because that's the most distal projection. There's going to be that fairly significant space between the ulna and the tricretium. The better way to actually find the hamate is come to the palmar side. You can, again, when you're trying to find an obvious, maybe not so obvious landmark, palpate broadly initially. Instead of, you might not be able to go right to it like that, but if you can palpate broadly, you'll feel the pisiform. And you can palpate all around that pisiform, make a circle all the way around it, and you can feel pushing into it. I can very clearly outline that pisiform. If I come proximal to the pisiform, I'm in a tendon. So right now I'm running over top of a tendon. So what I'd like you to do is flex your wrist, and that tendon pops right up into my finger. That's a flexor carpi ulnaris. If I want that tendon to pop out even more, I'll have that muscle do everything that it likes to do, or everything it's capable of doing. I'll have it flex as well as ulnarly deviate. And there, that tendon is very obvious. It's popping out into my finger because my finger is now proximal to the pisiform where it attaches. Okay. So the hamate, if I find my pisiform again, here's my pisiform, and generally speaking, the hamate is about a finger's breadth, distal and lateral. So here's pisiform, and I'm guessing my hamate is going to be about there. Okay, so about a finger's breadth. And so I'm going to get the hand to relax some, and I'm going to push into that. And sure enough, I feel a firmness there. If you're not sure if that's a firmness, push somewhere else where you don't think the firmness is, right? So you can feel soft versus firm. The real way to confirm this is to say to the patient, is that a little bit tender? Because usually the hook at hamate's a little bit tender because the flexor and the opponent's digiti minimi both attached there, right? So now I've got the hamate on the palmar side and the dorsal side. Okay, I can get my tricretium if I come back to my pisiform. This isn't a good position for my wrist, but you get the basic idea. Here's pisiform, here's hamate. So I can move the tricretium relative to the hamate by finding those landmarks. Okay. We can palpate the anterior tubercle or the tubercle of the scaphoid. Again, go back to the snuff box. Find the scaphoid, ulnarly deviate. Snuff box, make your snuff box for me. Okay, relax. So there it is, just popped into my hand. Now if I go to the anterior side and I extend the wrist, that very prominent bone which sticks out kind of in the area where you take the radial pulse, that's the anterior tubercle of the scaphoid. Okay. To palpate we've palpated the CMCs, let's palpate the MCPs. So this would be at the heads of the metacarpals and the bases of the proximal phalanges. Right. So I know that this joint is flexion extension in this direction. There's only flexion extension actively at this joint, whereas flexion extension of CMC is here. AB, a deduction of that first CMC is this direction. Right. And generally, if you're trying to find a joint space, right, you're going to palpate. The joint space is going to be around this way, right, because it's the base of the proximal phalanx and the head of the metacarpal. So if I palpate not along the length of the divot, but across the divot, I'll be able to feel that joint space even more. So you can palpate all along that joint space. And you can do that with all of these metacarpal phalangeal joints. You can even do it to a lesser degree or less easily at the PIP and DIP joints. Find what you think is the divot in between. It might even help to distract a little bit, so now I'm giving a little bit of distraction. So I put my finger over where I think is the joint space, and then I give a little distraction. Sure enough, I'm feeling that divot open up right there.